Hello. General concepts. So on malnutrition, encompass the full continuum of undernutrition and overnutrition of both macro and micronutrients. WHO definition is its imbalance between nutrients and demand of the body. The greatest risk of undernutrition occurs in the first 1000 days. Many poor nutritional outcomes begin in the uterus and are manifest as of less than 2500 grams. The prevalence of malnutrition. Low birth weight are highest 26% in South Asia and are as twice as those of Sub-Saharan 2011, 16% are under or standard deviation of less than -2. According to the prevalence of GAM at national level to be around 9%, and the prevalence was stated to be 40%. Fetal growth, suboptimal breastfeeding, stunting, wasting, deficiency of vitamin A and zinc jointly contribute to 45% of global child deaths, 3.1 million deaths. Cause of undernutrition. Nutritional status is determined by three factors: immediate cause, underlying cause, and basic cause. Immediate causes act on the individual. These are inadequate food intake and infection with their vicious cycle. Underlying causes influence in the community. These are drought, flooding, household food insecurity. So the basic cause influence communities and societies. These include country's economy and political status. So immediate cause act on the individual, inadequate food intake or infection with their life vicious cycle. The other is underlying cause. These are household and community under community and household. And the basic cause, this include the country's economic and political status. Consequence of undernutrition. So one is premature death. Undernourished women give birth to low birth weight babies. Low birth weight and low weight gain in the first 2 years are increased the risk of stroke and stunted children less than 3 years, motor and cognitive development, and altered behavior in later years. Iodine and iron deficiency also lead to loss of potential. Assessment of nutrition, so ABCD. So the first one is anthropometry, the study of and technique of human body measurement used to measure and monitor nutritional status of individual or population group. Chemistry. So the second is biochemistry, measures the level of chemical substance present in the blood. So biochemistry measures the level of chemical substances present in blood like hemoglobin, albumin, CRP, hemoglobin A1C, sodium, urea, calcium, phosphate, magnesium, and micronutrients. Functional tests measure the function of vital organs such as kidney or liver. On clinical, different clinical manifestation of malnutrition on different organ systems and diseases that result malnutrition by increasing nutritional requirement or decreased appetite. So on dietary, estimation of total dietary calorie intake as well as overall quality of diet is assessed. It's helpful to understand pattern of eating, portion size, cooking methods, and type of food and drink taken. So classification. There are two ways of classifying malnutrition. These are community survey and clinical. So on community survey, we have different ways of classifying. The first is the Gomez underweight combined wasting and stunting index. So it classifies, it grades malnutrition as mild, moderate, and severe. Waterloo classification, Waterloo wasting and stunting classification, WHO wasting and stunting classification, and so on. So on WHO wasting classification, it classifies using the mark between the ages between 6 months and 59 months, for ages 5 to 9 years, for ages 10 to 14, and for ages 15 to 18. So according to WHO wasting standard, so children less than MOAC less than 115 millimeter is called severe, whereas MOAC between 115 and 125 millimeter is moderate, and normal is greater than 125 millimeter. So WHO further classifies severe acute malnutrition as complicated and non-complicated. So there are also Wellcome's classification. It classifies as marasmus, kwashiorkor, or marasmic kwash. So in marasmus there is severe wasting, severe weight loss and muscle loss, leaving skin and bones. And kwashiorkor characterized by edema, nutritional edema, that is clinical indicator for some. And marasmic kwashiorkor, severe wasting plus edema, and combination of kwashiorkor and marasmus. So on some is so severe acute malnutrition, it is severe wasting of MOAC less than 11.5 centimeter for ages between 6 and 59 months, and weight for height of less than -3 standard deviation, or bilateral pitting edema for infants between 0 to 6 months, recent weight loss or failure to gain weight, or ineffective bleeding, ineffective feeding, attachment, position, or sucking. So on clinical presentation, two clinical syndromes of malnutrition, undernutritional, were recognized with their own pathophysiology and presentation. These are edematous sum and non-edematous sum. Also on pathophysiology, it's orderly progressing physiologic and metabolic changes to conserve energy and prolong life. This process is called reductive adaptation. It's orderly progressing physiologic and metabolic change to conserve energy and prolong life. This process is called reductive adaptation, often in marasmus, that is reduced body homeostasis in order to survive on limited macro and micronutrients. Atrophied organs and less functional organ systems, the function is preserved. So atrophied organ and less functional organ systems, the function of organs is preserved more in non-edematous sum than edematous. So there is compensatory breakdown of muscle proteins in non-edematous sum, makes the reduction in serum proteins to be less extent. So this adaptation results in small bowel overgrowth, infection, free radicals, toxin accumulation, while low antioxidant and disposal. This results in tissue damage and development of kwashiorkor. So failure of compensatory mechanisms in long-standing non-edematous sum will lead to development of edema or kwash marasmus. So 4 different theories are proposed for the pathogenesis of kwashiorkor. So the first one is protein energy deficiency, aflatoxin free radical theory, summarized as classic protein deficiency theory. So newer free radical damage theory, so imbalance between production and disposal of free radicals, impaired antioxidant defense mechanisms because inadequate toxins from infection and aflatoxins. So on approach to malnutrition, so on history, ages between 12 to 36 kwashiorkor. It usually occurs at the time of weaning, initiation of adult diet, which is high in carbohydrate but low in protein, severe protein and privation while adequate caloric intake. So for marasmus, age at presentation is between 6 and 12 months, so infantile marasmus. In non-breastfed or inadequately breastfed infantes, late marasmus in older children living on inadequate diet for prolonged periods. Both protein and carbohydrates are inadequate. Symptoms directly resulting from undernutrition, so kwashiorkor, there is generalized body swelling starting from the legs, loss of appetite, vomiting and abdominal distension, diarrhea as a result of maladaptation, bacterial overgrowth, growth retardation, and mental changes together with GBS are 3 essential features. So there is growth retardation, mental changes together with generalized body swelling. Symptoms of anemia, vertigo, easy fatigability, listlessness, tinnitus, pica are also there. On marasmus, there is growth retardation, failure to gain weight, earliest manifestation, irritability, continuously crying because of hunger, poor appetite, unlike kwashiorkor, diarrhea, and symptom of micronutrient deficiency. So in marasmic kwashiorkor, there are both clinical features. Acute or chronic protein deficiency in patient with chronic energy. Muscles of upper limb are wasted while lower limb appear swollen. So symptoms. So the first is from symptoms resulting from complications of undernutrition, fever, chills, malaise, may not be apparent because of low immune. On respiratory system, there is cough, fast breathing, dysuria frequency and urgency, ear and eye pain. So the second is hypoglycemia and severe case twitching, convulsion, limplessness and loss of consciousness. On hypothermia, patient may shiver and be drowsy, corneal ulceration, vitamin deficiency, night blindness because of absence of rhodopsin, late stage complete blindness or refractive defect because of corneal ulceration or scarring. So risk factors are inadequate food intake due to scarcity of food. So primary malnutrition, commonly seen in children less than 5 years. Factors that decrease absorption, so increased metabolic requirement and decreased appetite, are secondary malnutrition. So primary ones are due to food scarcity of food, secondary one due to decreased absorption of food, increased metabolic requirement, and decrease in appetite. So inadequate food intake, so that is due to infection or chronic illness. Inadequate feeding due to scarcity of food or economic status. Decreased absorption of nutrients, AIDS, enteropathy, intestinal TB, intolerance. In many of these cases, children may present with failure to thrive and chronic or persistent diarrhea. Increased daily nutritional requirement. Physiologically, children and adolescents have more nutritional requirement. Others are infection, parasites, especially hookworms, schistosomiasis, malaria, and blood nutrient needs. To assess those risk factors, it's important to assess the following: patient history, nutritional intake of the patient, past or present medical history, personal and family and social history. Also consider asking immunization history because infection is common as complication in children and one of the immediate causes. Also on physical examination, we may see moon face. So moon face sparing the periorbit, and apathy, Simon face or visible wasting. So this is Simon face, Simon old face. This is due to whereas on moon face this is due to kwashiorkor. Also on physical signs, there may be hypotension because of bradycardia, due to electrolyte abnormality and decreased mass of the ventricles. Respiratory rate may be tachypneic because of pneumonia. There may be fever or hypothermia. Hypometry. So there is a BMI is less than -12 standard deviation. Weight for height or weight for length is indication of acute malnutrition. Weight for age, easy to measure but doesn't differentiate between stunting and wasting. Height for age and length for age, measure of linear growth. Deficit represents the cumulative impact of adverse effect. And MOAC, it's community level screening. So on HNT, on head, there may be craniotapes, frontal bossing, delayed frontal nerve closure, which is due to vitamin D deficiency. Skeletal changes seen in rickets may not be present in children with some, because rickets is disease of growing bone, and so skeletal changes is seen in rickets may not be present in children with some, because rickets is disease of growing bone and children with some are in reductive adaptation. So on dry eyes, pale conjunctiva, non-icteric sclera, periorbital edema, so maybe seen in broomstick eyelashes, eyelid retraction, maybe seen in hypoglycemia, sunken eyeballs due to atrophy tissue, maybe seen in dehydration, vasoconstriction of orbital venous plexus, so also seen in dehydration. So Bitot spot, xerophthalmia, and keratomalacia. On ear, signs of otitis media, tragus and antitragus tenderness. On nose, bleeding, nasal bleeding. So on nose, there may be bleeding from nasal mucosa. On mouth and throat, dry oral mucosa, oral thrush, angular cheilitis, glossitis, spongy bleeding gums, maybe sign of vitamin D deficiency. Also on lymphoglandular system, so on respiratory system, there may be visible wasting, costochondral beads. It's seen in vitamin C and D deficiency, Harrison's groove, cryptation, decreased breath sounds, dullness because of pneumonia and CHF. On CVS, raised JVP, small vessel vasculopathy, weak pulses, slow capillary refill. On abdomen, there may be port belly, hepatomegaly with fatty liver, is only seen in kwashiorkor, fluid thrill and shifting dullness. On musculoskeletal system, edema characterized as pitting and non-pitting, grade 1 to 3, muscle wasting and ties, baggy pant appearance, sagging skin around the buttock of the patient, seen here. Signs of hypocalcemia, Chuvostek sign, twitching of the face while striking the angle of the jaw, and Chausu sign, flexion of the metacarpopharyngeal joint and extension of interpharyngeal joint while inflating the BP cuff. Skeletal deformities, integumentary. So there may be cold and clammy skin. So on shock, loose and wrinkled, shiny and edematous in kwashiorkor. So differential skin manifestation of malnutrition. So acrodermatitis intrahepatica, so inability to absorb sufficient zinc from diet. Symmetric vesiculobulous thoraciform skin lesions on perioral, acral and perineal areas. A serum zinc of less than 50 microgram per DL is suggestive. Chronic diarrhea, stomatitis, glossitis, paronychia, nail dystrophy, growth retardation, inability or delayed wound healing and infection. So are the manifestations. So essential fatty acids, generalized scaly dermatitis with thickened scaly plaque, failure to thrive, alopecia, poor wound healing, and thrombocytopenia. Quash dermatosis, there is diffuse fine reddish brown scaling. There is clinically graded as grade 1, so it's localized in hypo or hyperpigmentation. Grade 2, localized patchy discomating lesion. On grade 3, secondary lesion with fissure, ulcer and exudative lesion with bacterial infection. There may be pellagra, inadequate intake of or malabsorption of niacin and tryptophan. So there may be edema, erythema, burning of skin, sun-exposed skin provoked by burns, friction or inflammation, butterfly distribution on face and Kazan necklace, blister and scale. Skin is increasingly become dry and rough, thickened, cracked and hyperpigmented. On vitamin A deficiency, proliferation of basal cells, hyperkeratosis, and formation of stratified cornified squamous epithelium, hyperplasia of epidermis lining the hair follicles and sebaceous gland. So dry, scaly and hyperkeratotic patches on the arm, legs, shoulder and buttocks, and there may be vitamin C deficiency. So follicular hyperkeratosis, coiling of the hair on upper and lower extremities, vascular fragility because of vitamin C is essential for collagen synthesis, perifollicular erythematic particularly on the legs, and hemorrhage of gums and subperiosteum. Best diagnosed with vitamin C supplementation test. So on here, there may be dull sparse alopecia, broomstick eyelashes, brownish discoloration, flags and interchanging periods of protein deficiency and inadequacy, brownish discoloration due to low melanin production because of low serum amino acids. Easy pluckable hair is plucked by the examiner without inducing pain. Nails show coelinecia, thin soft nail beds, fissure and ridges. On neurologic, There may be lethargic, apathy, irritable, weak reflexes, impaired memory. So an investigation diagnosis of SAM is clinical, but investigation to look for complication and underlying cause depending on the evidence we have from history and physical examination, CBCR based organ function test, serum electrolytes, chest x-rays to examine biofilm. Those are the investigations. So complications are infections. An immediate cause can result from low immunity, poor prognosis owing to young age of the patient, severity of infection, and presence of complications. Bronchopneumonia and gram-negative septicemia are common infections. Second is hypoglycemia, serum glucose level of less than 54 mg per dl, most seen in marasmus and is not common to be symptomatic. It's often associated with septicemia, and early and adequate feeding usually avoids this complication. So the third complication is shock, feared emergency. So feared emergencies, complications in some can be hypovolemic or septic. Immediate diagnosis and appropriate management is critical. Patient may be lethargic or unconscious. Hypothermia, medical emergency in malnourished patient, often in severely wasted children, is associated with high mortality, result from impairment of thermoregulatory control and decreased energy stores. In addition, the loss of thermal insulation because of emaciation. So severe anemia, that is the other complication. It is when hemoglobin is less than 4 gram per dl or hematocrit less than 12%. Has different causes: iron, folate deficiency, low serum protein, blood loss like hookworm, anemia of underlying chronic illness, corneal ulcerations. So eye changes rarely occur before they keratinitis, become opaque and is susceptible to infection from dry scaly layers of the eye called xerophthalmia. Infection develop and cornea degenerates irreversibly. Corneal ulceration, keratinization of conjunctiva and Bitot spots, other dehydration, electrolyte imbalance, skin lesions, HF. So management has two steps of treatment. One, stabilization, shock. So shock, hypoglycemia and severe dehydration, very severe anemia and corneal ulceration needs emergency treatment. Stabilization phase, repair cellular function, correct fluid and electrolyte imbalance, restore homeostasis, prevent days from interlinked trials of hypoglycemia, hypothermia and infection. So the main goal is to treat those. So on rehabilitation, the rehabilitation phase restores the wasted tissue, that is catch-up growth. It's essential that treatment proceeds in an orderly progression and that the metabolic machinery is repaired before any attempt is made to promote weight gain or correct deficiencies. For example, iron should not be given to severely malnourished child who can't make hemoglobin because of reductive adaptation in order to prevent accumulation of iron in excess. So on management, so admission criteria for stabilization center is young infants between 0 and 6 months. If any of these are present, they should be admitted. That is, weight for length less than -3 standard deviation, any grade of bilateral pitting edema, recent weight loss or failure to gain weight, ineffective feeding, presence of signs and symptoms of medical complications, and so in this case they should be admitted. So between age and 59 months, if any of this is present, bilateral pitting edema of grade 3, bilateral pitting edema of grade 1 or 2, severe wasting like MOAC less than 11.5 cm or weight for height less than -3 standard deviation, plus bilateral pitting edema of any grade, weight for length or weight for height is less than -3 standard deviation or MOAC of less than 11.5 cm, and any sign of medical complication or failed appetite test or referred from outpatient care. So age group is between 5 and 18. So if any of these are present, weight for length or height is less than -3 standard deviation or Z-score, MOAC in severe category, BMI for age is less than -3 standard deviation, edema on both feet of +1 and +2 plus any of one of the medical complications or failed appetite test, grade 3 edema, they should be admitted. So in marasmic kwashiorkor, So weight for length or height is less than -3 standard deviation with edema, or MOAC in severe category with edema. So criteria for outpatient therapeutic program. So for aged between 6 and 59 months, bilateral pitting edema grade 1 or 2, MOAC less than 11.5, weight for height less than -3, appetite test passed, no medical complication, clinically well and alert, or referred from stabilization. So on management of SAM in stabilization phase, in phase 1, treatment is always given in patient care setting during this phase. So life-threatening medical complications are treated. Routine drugs, vitamin A, folic acid, antibiotics, and deworming are given to correct specific deficiency, and feeding with F75 milk, low caloric and low sodium is begun. Folic acid is not necessarily given if F75 is 45 according to WHO requirement, if the patient has no ocular manifestation. So on transition phase, here the patient are going to be presented for phase 2, that is rehabilitation, and F75 in phase 1 is changed to F4. Transition is done when patient improves appetite and complications are treated. So criteria to transfer patients between phase of management is as follows. From phase 1 to transition phase, so one criteria is return of appetite, so easily finishes the F75 feeds, subsiding bilateral edema or minimal edema, no serious medical complications like vomiting, watery diarrhea, dehydration, respiratory distress that needs NAGT or IV line. So to return back from the transition phase to phase 1, so signs of fluid overload develop, like weight gain more rapidly. So weight gain more rapidly than 10 kg, associated with increased respiratory rate, rapid increase in size of the liver, increasing edema, appearance of new edema if tense abdominal distension develop, if the patient gets significant refeeding diarrhea, so that there is weight loss, if the patient develop medical complications, or if energy tube is IV line is needed. So recovering patient can progress to outpatient therapy. Only those who cannot so on phase 2 can be given both inpatient and outpatient. So vigorous approach to feeding is required to achieve very high energy intake and rapid weight gain of greater than 10 gram per kg per day. So on phase 2, so when treating the patient in outpatient is not reasonable, no capable caregiver, no enough energy supply of RUTF, and patient doesn't tolerate RUTF. So that is inpatient treatment, whereas in phase 2 outpatient, there is a capable caregiver, enough RUTF, and OTP program is near home. So in that case, we can treat them as outpatient. So F100 is never given in outpatient care. In patients in phase 2 who develop any sign of complication or any clinical deterioration should return to phase 1. So return from transition to phase 2 feeding. So transition takes 2 to 3 days. So good appetite, taking all the F100 or greater than 75% of RUTF or for OTP. Definite reduction of edema, so grade 1 or 2. So for wasted patient, complete absence of edema, medical complications are resolving, clinically well and alert. So this can transition to phase 2. So from phase 2 to phase 1, any clinical sign of complication, increased development of edema, development of refeeding, diarrhea, sufficient to lead to weight loss for 2 consecutive waiting, static weight for 3 consecutive waitings, fulfilling any criteria of failure to respond to treatment. So every treatment option should be followed to assess response and possible complications. Good response are measured by good weight gain of greater than 10 gram per kg per day, gain of appetite, resolving edema are critical to transfer patients to next phase of management. Failure to respond to treatment can be primary or secondary. So criteria to label a patient has failed to respond. So children in phase 1, so there is primary failure to gain appetite at day 4, failure to start to lose edema at day 4, edema still present at day 10, failure to enter phase 2 and gain more than 5 gram per kg per day at day 10. Child in phase 2, secondary failure, failure to gain weight at least 5 gram 3 consecutive days after feeding on of failed treatments. Confirmed increase in pulse rate of greater than 5 beats per minute, with confirmed increase in respiratory rates of greater than 50 breaths per minute in child in 2 to 12 months, greater than 40 or more in child in 12 months than 35 or greater than 38.5. Any sudden increase or decrease axillary temperature within normal range. Other danger signs include anorexia, jaundice, bruising, large weight gain, mental changes. So for infants between 0 to 6 months, management should focus on prioritize reestablishing effective elusive breastfeeding, promote and support the mother or caregiver to breastfeed, assess the physical and mental health status of the mother or. So discharge criteria: stabilized and transferred to outpatient. So passed RUTF appetite test, the child eats more than 75% of daily RUTF. Medical complications are resolving, bilateral pitting edema is decreasing, clinically well and alert. So between infant, so for 6 months, infant is feeding well and there is a replacement feed for non-breastfed infants. Successful lactation, effective breastfeeding, adequate weight gain on feeding, has adequate weight gain and has weight for lengths of greater than -2 z-score. No bilateral pitting edema, clinically well and alert. Infant has been checked for immunization and other routine interventions. Mothers or community-based follow-up, discharged after full recovery. So anthropometric indicators as used to confirm some should be used to assess whether recovery. If admitted with bilateral pitting edema, discharge cured. When no bilateral pitting edema for 2 consecutive visits and more centimeter, weight for length to weight for height is greater than -2 SD and clinically well. So this is it